Welcome back to another Deep Dive Explainer. Today, we are tackling a diagnostic puzzle that absolutely demands precision: decoding chronic hydrocephalus. We're going to meticulously break down the specific imaging features, dig into the tricky conditions that mimic it, and finally clear up those historical misnomers that just muddy the waters. We're covering every single point so you won't miss a thing. Let's get right to work.
All right, here's our roadmap for this explainer. 1. Cranial and ventricular signs. 2. Corpus callosum and infant-specific signs. 3. The mimics or pseudohydrocephalus. And 4. The misleading misnomers.
Starting right off with Section 1, cranial and ventricular signs.
Our very first feature is the classic beaten copper cranium. You might also hear it called a beaten silver appearance. You'll usually spot this right away on a plain skull X-ray. Now, it's super tempting to see this and instantly assume, aha, high intracranial pressure. But hold on. By itself, a beaten copper appearance does not guarantee high ICP. It actually only suggests increased pressure if it's explicitly paired with changes to the sella or the temporal horns, which we'll look at in a second. Oh, and keep in mind, you can literally see this exact same beaten copper pattern in craniosynostosis. So context is everything.
That brings us to features 2 and 3, which are basically a chain reaction. On a CT or MRI, you might see the third ventricle physically herniating, just pushing right down into the sella. You know, that bony pocket holding the pituitary gland. Because of this downward herniation, you get our third feature, the actual erosion of the sella turcica, specifically the dorsum sella. It's this relentless physical pressure from the herniated third ventricle that sometimes leaves you with an empty sella appearance on the scan.
Feature 4 is all about temporal horn prominence, and honestly, this is where things get a little counterintuitive. You'd probably assume that chronic, long-standing hydrocephalus would mean these massively blown-out temporal horns, right? Well, actually, scratch that. The temporal horns may be notably less prominent on imaging in chronic hydrocephalus compared to what you'd see in acute, sudden-onset cases. It's a really vital distinction to make when you're comparing those scans.
Moving to feature 5, we have macrocrania. We don't just eyeball this. Macrocrania is strictly mathematically defined. By convention, it's when the occipitofrontal circumference, the OFC, measures greater than the 98th percentile. To put that into perspective statistically, we're talking about a measurement sitting a full 2 standard deviations above the mean.
Let's shift gears to Section 2, corpus callosum and infant signs.
For feature 6, you really have to change your vantage point. We're looking at changes to the corpus callosum, and these findings are absolutely best appreciated on a sagittal MRI or CT. When you pull up that sagittal slice, you're hunting for 2 distinct things. First, atrophy, so a noticeable thinning of the corpus callosum. And second, a really distinct upward bowing of the structure, almost like it's being stretched from underneath.
Feature 7 focuses strictly on infants. Because an infant's skull hasn't fully fused yet, chronic hydrocephalus is going to present with unique mechanical warning signs. You're going to see sutral diastasis, which is the physical splaying or spreading apart of the cranial sutures that you can easily spot on a plain skull X-ray or CT. And right alongside that splaying, you'll naturally observe a markedly delayed closure of the fontanelles. The skull is literally stretching to accommodate the pressure.
All right, Section 3, the mimics. This is often called pseudohydrocephalus, and it's where things get really tricky.
Let's talk about hydrocephalus ex vacuo. When you see those enlarged ventricles on a scan, your brain might immediately scream, hey, inadequate CSF absorption. But wait, the crucial point here is the mechanism. In hydrocephalus ex vacuo, the enlargement is strictly due to the loss of cerebral tissue, cerebral atrophy. The brain tissue itself shrinks, and the ventricles just passively expand to fill the empty vacuum. It absolutely does not represent a plumbing issue or altered CSF hemodynamics.
So what's actually driving that loss of brain tissue? Well, frequently it's just a function of normal aging, but this atrophy can be severely accelerated by specific disease processes. As we've listed out here, conditions like Alzheimer's disease, Creutzfeldt-Jakob disease, and traumatic brain injury, they all rapidly increase cerebral tissue loss. That makes the ventricles look huge, simply by comparison to the shrinking brain mass around them.
Beyond just tissue loss, we also have structural developmental anomalies that act as mimics. The first one is agenesis of the corpus callosum. Now, to be totally precise, this can occasionally be associated with true hydrocephalus, but very often,
The image you're looking at merely represents an expansion of the third ventricle and a separation of the lateral ventricles simply because the corpus callosum isn't there to hold things together. It gives a completely false impression of hydrocephalus. Another critical developmental anomaly to watch out for is septo-optic dysplasia. In this condition, specific portions of the ventricles may just naturally appear enlarged. So again, it acts as another visual mimic, totally tricking the eye into suspecting a CSF absorption issue when, functionally, none exists at all. Our final developmental mimic is a heavy one, hydranencephaly. This is a post-neurulation defect causing a total or near-total absence of the cerebrum, most commonly resulting from bilateral internal carotid artery infarcts. And I really want to pause here because this distinction is absolutely vital. You have to differentiate hydranencephaly from severe maximal true hydrocephalus. Why? Because if you surgically shunt a patient with true severe hydrocephalus, you might actually produce some re-expansion of the cortical mantle. You simply cannot achieve that in hydranencephaly, because the cerebrum literally isn't there to re-expand.
Finally, Section 4, the misleading misnomers. Let's look at these two historic terms side by side, because they do us zero favors today. First, otitic hydrocephalus. This is an entirely obsolete term. It used to describe the increased intracranial pressure seen in patients with otitis media, basically serving as an early term for pseudotumor cerebri. It's completely misleading now. On the flip side, we have external hydrocephalus. This is seen in infancy, characterized by an enlarged subarachnoid space and an increasing head circumference. But, and this is the kicker, if you look at the ventricles, they are either totally normal or just mildly dilated. So calling it hydrocephalus is a massive misnomer. And that brings us to the end of our point-by-point breakdown. But I want to leave you with a provocative thought before we wrap up. If a mimic, like hydrocephalus ex vacuo, visibly alters the physical shape of the ventricles without fundamentally changing the CSF dynamics, how does maintaining strict, precise terminology reshape our ultimate treatment plan? When we take the time to differentiate tissue loss from fluid buildup or a developmental anomaly from an active pressure crisis, we aren't just arguing over semantics. We are literally saving patients from surgical shunts they do not need and ensuring those who do need them actually get them. Definitely something to think about the next time you review a scan. Thanks for joining me on this explainer, and I'll see you in the next one.